Am I audible? Hello?
Yeah,
Good evening, everyone. I'll just give you a little introduction to our next speaker, Professor Jayashree Kalpati Kramer. She is the director of QTIM Lab and the Center of Machine Learning at the Athenola A. Martinos Center for Biomedical Imaging, and also an associate professor at Howard Medical School. Dr. Kalpati Kramer is also the scientific director at MGB Center for Clinical Data Science and a senior scientist at the American College of Radiology Data Science Institute. She had completed her BTech from IIT Bombay and her PhD from Rensselaer Polytechnic Institute. I could go on and on about her work, her achievements, and affiliations, but I think we should just proceed to the talk now. So over to you, Professor.
Thank you so much for the introduction, and thank you also for the invitation to speak here today. This morning or this evening, I'll be talking a little bit about some of the work that we do in our lab in the area of using AI for medical imaging and some of the challenges and opportunities for building robust algorithms. This is a work of a number of people in our lab, as listed here. So, as I'm sure many of you have seen over the last few years, as deep learning methods are getting more popular and more capable, there's a lot of enthusiasm about their use in medicine and medical imaging. In fact, it got so bad, so optimistic, and so much of a hype that these are the sort of things that people started saying about whether radiologists should be worried about their jobs. We can now diagnose as well as radiologists, or even better than radiologists. There was a lot of talk about whether you're going to be seeing essentially machines instead of seeing doctors. And even today, what we see is a lot of very optimistic and very language that's full of hype. So we'd always see things like dermatologist level classification, cardiologist level, expert level. And this continues to be something that we see in the literature a lot. This is something that we really need to think about carefully in terms of how much of this is reality versus hype. In addition to all of what we see in terms of the capability of these algorithms for what they can do, which is essentially do the same sort of things as an expert might do, we are also starting to see the ability of these algorithms to do things that an expert may not be able to do, such as predicting cardiovascular risk factors from fundus images. If you actually ask an ophthalmologist to try to predict these things, including smoking status or other factors from a fundus image, it's not something that expert ophthalmologists are trained to do, but these algorithms seem to be potentially capable for some of these methods. As a consequence, we are seeing a lot of applications of these algorithms across domains that use medical imaging. So this is dermatology, cardiology, pathology, neurology, radiology, and many, many fields, especially where we've seen the ability to use medical images for diagnosis. If you look at the set of algorithms that have been approved by the FDA in the US, so for instance, in the US, if you need to use an algorithm in the clinic, it needs to go through an approval process by the FDA to get approval. And this is some of the examples of algorithms that are actually been approved for the FDA. And one thing you'll notice is that a number of them are in radiology. Some others are in ophthalmology, pathology. In many, many of these cases, what we see is that medical imaging is where a lot of progress has been made in terms of getting algorithms to the approval process. However, there's a lot of challenges in terms of medical images compared to, say, street images or sort of more standard computer vision type problems. Medical images can be 2D, 3D, 4D, 5D type images. They tend to be much higher resolution than we typically tend to see very often in the more common ImageNet type data sets. As a consequence, the part of the image that's actually of interest might be tiny compared to the whole image. So for instance, if you're talking about a mammogram, it's a very high resolution image, but the area of concern can be really, really small. And unfortunately, when you downsize these images, as is very common, in order to, for instance, use a pre-trained network, we might lose a lot of the important information that is necessary. Additionally, the data sets tend to be small. We typically don't have this kind of data sets that we have in computer vision with millions and millions of images. These tend to be in the orders of somewhere from hundreds to thousands being large data sets. So unfortunately, again, that means some kind of pre-training is optimal, but it's hard to find the appropriate pre-trained networks that can be used more easily. The annotations are very expensive. We need experts and doctors to make the annotations, and that is a very, very expensive process. And thus, getting good ground truth can be also a challenge. And ultimately, if you make a mistake, it's a very, very serious issue. And so we'd be very careful about how we use these images and the output of the algorithms in this situation. Very typically, we have at least in medicine, in medical imaging, what we tend to see to date has been more supervised tasks. So a fairly common set of tasks tends to be things like classification, detection, or segmentation. Pneumothorax is essentially a collapsed lung, and an X-ray is used to detect that. And the same problem can be formulated in a couple different methods. So you can say, given an X-ray, does this patient have pneumothorax or not? You can say, you are interested in detection, so exactly where is the pneumothorax? And so you might want to use something like a bounding box and a detection type network. You might want to find the boundaries of the pneumothorax, so you might actually have a segmentation task. So the same overall clinical question can be formulated in a couple different ways that is more appropriate for different network architectures. So a fairly standard classification network, or something like a retina net or detection network of some sort, or a UNet for segmentation. So it is really important to work closely with your clinical colleagues as you're developing these algorithms to understand exactly what it is that they are trying to do and how best to structure the network to to provide an answer that is most useful. For instance, if you have a classification network, you may really have no idea where the pneumothorax is. And the clinicians get very upset if they, for instance, if the algorithm says it's a positive case, but they're not able to find it. So some of the concerns about black box algorithms is something that really needs to be thought about. Is if you have a completely black box algorithm with no idea as to why the network is making the decision, that makes the clinicians a little uncomfortable. So trying to think about more explainable architectures, such as detection or segmentation networks, is definitely worth considering. In classification tasks are very, very common. Some examples are things like, is this a malignant or benign lesion? So for instance, people get CTs of the chest to look for lung nodules, or they might get mammograms, they might get many different, in oncology, this is pretty common, to get a screening scan to try to see if there's a abnormal finding or not. And a very common task here is it a benign versus malignant lesion? Other types of things that we've seen good algorithms for is in diabetic retinopathy, for instance. And here it's not a binary classification, but rather a ordinal class. So what is the level of how severe is the disease in this particular image? Is this chest X-ray normal or not? That's slightly different than is it a benign or malignant, because in the case of normal or not, there might be a lot of different things that might be abnormal. So you might have pneumonia or pneumothorax or masses. Versus it's perfectly normal. We're looking at things like polyps. So a lot of these are fairly common tasks that we see in medical imaging. A regression task is something like what we saw in the bone age challenge. Here, essentially what clinicians do is actually take a X-ray of the hand of a baby or a child to see if the growth is normal. And so the goal is to try to predict the age based on the scan of the X-ray of the hand. And so training a regression algorithm is something that is, again, a common approach for these sort of tasks. Going, again, from the perspective of medical imaging, it really depends on how you frame the task and what the task is. So is the annotation as a patient level, meaning does this patient have cancer or not? Or is it at the study level, meaning that at this particular time you take many different scans? Is it that all of the scans, are you saying that there's some finding or not? Is it as a series level? Again, in medical imaging, what you typically tend to do is when you go get an MRI, there are many different types of sequences that are acquired, and each of them shows slightly different things. Some might show soft tissues, some might show bone, some might show air. So depending on what it is that is of interest, slightly different ways of acquiring the images are used, and they provide different information. And so the annotation might be at what is called a series level. In a 3D volume of the lung CT, for instance, you might provide an annotation at a slice level or an instance level. And finally, you might provide the annotation at a voxel level. So depending on what the question is and how you want to frame the problem, the annotation needs to reflect that. The next question is, how many images do you need? And it really depends on whether you're using a pre-trained network or not. We typically see a huge impact of using a pre-trained network. Unfortunately, of course, that means that you're somewhat limited in the kind of architectures you can use. So if you're using an ImageNet pre-trained network, that really is limiting in terms of what you can do. On the other hand, we typically do not tend to have enough images to start training from scratch. Annotations can be very, very noisy. So here is an example of annotations from multiple doctors. For the same image, 8 different doctors were given the same image and asked to grade it in a 3-level task. So this is for ophthalmology, it is retinopathy premature, and the goal is to say, is it normal, mild, or severe? And what you can see is for this particular image, so each of these columns is an image, each of these rows is a doctor. You can see that this doctor tends to have a lot of light blue and this medium blue and not as much of the dark blue, versus this doctor tends to have a lot of dark blue. So you can see that the same image can be annotated quite differently by different experts. This image, everybody agreed, is dark blue. This image, half and half were light and medium blue. And so we see quite a bit of variability. Of course, that means that you need not more data because the data tend to be noisy. And this is a fairly common observation in a lot of medical tasks, is that if you're asking experts to make their annotations, there can be quite a bit of variability between them. And that needs to be taken into account as you're training the algorithms to create your algorithms. I'm now going to talk about very specific algorithms that we do and how we set these problems up, and then talk about some of the challenges as well. So brain tumors is a very deadly disease with a very, very poor outcome. And one of the ways in which we are using AI in brain tumors is in looking at response assessment, looking at prediction of survival, and so on. So this is work done by a PhD student in our lab, and I touch upon some of these aspects. So typically what happens is a patient might have a headache or come up with some neurological issues. They get a MR imaging, and in this case, they get multiple scans. They get a what's called a T1 weighted image with and without contrast. They may get a T2 and a flare. So these are different sequences of acquiring images that show different things. They might get a biopsy to get some histological markers, and based on that, they might get treatment, chemotherapy, radiosurgery, and so on. And then as the treatment is underway, there's a lot of interest in seeing if the patient is getting better, getting worse. Should we continue the treatment plan? Should we adjust the plan? And so something called RANO, or response assessment, is used to figure out if the patient is getting better or not. So how can some of these tools be used? So we can use for detection and delineation of the boundaries, for treatment assessments, for molecular markers, and so on. So here is an example of what these images look like. This is a flare image, and you can see it looks a little different from the T1 post-contrast image. And what you see is here is the tumor as seen on this sequence, and here is the tumor as seen as this sequence. But it's a fairly straightforward UNet type architecture can help train a pretty good network. Some of the challenges with this particular tumor is that the boundaries can be fuzzy. There can be a lot of variabilities. The normal structures can look like tumors. So that's where some of the challenges come in. Even though the architecture is not particularly novel, there's a lot of thought that needs to go into how you set up the problem in terms of what kind of augmentation schemes you use, what kind of essentially how you set up the problem as well. So as you see, as the network is training, it first thinks everything is a tumor, but then over time it starts to really separate between what is a normal enhancing area versus a tumor and gets a pretty good estimation of the tumor boundaries. So once you have the tumor segmented, you can then use it for response assessment. And the way clinicians typically measure this is using something called this bidirectional measure. So you essentially take two measurements of the tumor size. You find the size of the slice with the largest tumor, and then you measure that. And all of this sounds really easy, but it's actually quite variable. But once you have a good segmentation, it's fairly straightforward to now estimate the tumor measurements. So again, you can show that it's pretty reflective of the tumor size. We use it for vessel segmentation.
I think there are a few questions you can.
Sorry, go ahead.
Sorry to interrupt you. I think there are a few questions. You can maybe take those up before proceeding.
Sure. Yeah, please. Where? Okay. Okay. Good question.
The first question is, what exactly are 4D and 5D images, and where do they come from?
So essentially, when you're imaging a person, say you have, if you take a slice, that's a 2D image, right? You can take a view from this, from the front, or from across the body, or from that. Those are 2D images. If you have a 3D images, it's a volume. But a 4D is actually you have dynamic images. So you're imaging the same volume, but after giving contrast. So you see at each pixel, at each voxel, you have an intensity of over time. And so, so you have, for each 3D volume, you have intensity over time. So you add the time dimension to make it a 4D images. And then you also have multiple sequences. So you have, as we saw here, the flare and T1s, you have those across time points. So suddenly the dimensionality of the images is very high.
Okay, the next question is, for predicting cardiovascular risks from eye scans, if standard DL models are used, they may not capture causal relationships, but this is very important in especially a high-risk field like medicine. How is this tackled?
Agreed. It's unfortunately not tackled very well now. Most of what we are seeing right now is we really don't have any causal relationships. It's more associations rather than causal relationships. I think there is a lot more research happening in terms of bringing in causal relationships and counterfactuals and things like that. But most of what we've seen to date those are not taken into account, unfortunately.
Okay, the next question is, there have been attempts made for early prediction of diseases, but what approaches do you think one can work upon for diseases like brain tumor?
That is a hard problem because typically people don't get a scan unless there's a concern. So so there are some diseases such as lung cancer and breast cancer where people get routine screening, but for things like brain tumors, that's not considered clinical practice. So you don't just go get a scan every year to see if you might be developing a brain tumor. So what happens is typically by the time people have symptoms and come in, it's already pretty advanced. So that really is a challenge, is that for brain tumors, you don't know about it till it's almost too late.
Okay, one last question, and then we'll continue with your talk. We'll have the remaining questions later. So the next question is, how to make deep learning based regression models more generalized for glioblastomas subjects based on 3D MRI modalities?
I'm not sure I understand the question. So I'm not sure about the regression part of it, but to make it more generalizable. So what happens is when you have 3D MRI, a really challenging aspect of it is that the images can look quite different at different scanners. So for instance, an image acquired at my hospital might look very different than the image acquired at a different hospital. And so if I train an algorithm for just my data and I give it to my colleagues at a different hospital, these algorithms don't work. They can be quite brittle. And so there is a lot of thought in terms of how to do augmentation, how to do normalization, how to do all of these things to try to build some robustness into the algorithm. So how do we there's also physics that you can add into the mixture. So for instance, with slightly different settings what your image might look like. So you can start to think about using those kind of augmentation methods to build some robustness.
Thank you very much. I think you can proceed with the talk, and then we'll take the rest of the questions towards the end.
Okay. So again, a variety of things areas that people are working on is diabetic retinopathy, AMD. Here's a really interesting paper that came out not that long ago about essentially trying to use AI as a triage. So very often you go to get an eye check, they do a variety of tests, and they wanted to see if the algorithm can be trained to find many different diseases and identify those people that needs to be seen by an ophthalmologist. So an area that we work on is ROP, which is retinopathy of prematurity. It's a disease of low birth weight infants. And so it's really one of the leading causes of preventable blindness in the world. It really is an issue in places like India, especially where because of improvements in prenatal, in the NICUs, babies are surviving, but they tend to have potentially poor oxygen management and leading to blindness. So we've been doing a lot of work in this area where the goal is to identify essentially what's called an ROP, which is plus disease, which is a abnormality of the blood vessels in the back of the eye, and it's a hallmark of severe disease. And what we see is that the algorithm is actually very capable of identifying plus disease. We are working now with a number of collaborators, both in the US and India, in actually getting this into the clinic, and we hope to have a part of a screening program there. So similarly, we are using in pathology, so cell segmentation is something I think you heard about. There's a lot of different things that pathology is a really good area for these kinds of algorithms. It's 2D images, but it's large images, so you can work in patches, you can work in different ways. But cell counting, cell segmentation, classification, all of these things are fairly tractable problems using deep learning type methods. Radiation oncology is another area where there's a lot of interest. So when you have a cancer, for instance, and you're being treated with radiation therapy, the goal is to identify the normal tissues as well as the cancers. And so the way this happens is a clinician will segment out all the normal tissues. So here's a lung, here's a heart, and so on, spinal cord, and to make sure that you treat the cancer without affecting the normal tissues. And this is a task that's really, again, very amenable using deep learning methods. So because you can segment out all of these organs and really help in the treatment planning process. There's a number of colleagues who are developing these algorithms with the goal of deploying them, again, potentially in low resource settings, both in the US and elsewhere. Something to think about is in medicine, if you think about a radiologist's view of the world, there's many different kinds of imaging. So you have abdominal imaging, breast imaging, cardiac emergency, and so on. You have many different modalities. You have CT, you have MR, you have PET, and within each of these, you have lots and lots of findings. You have lots of anatomy. So the thing to think about, is that what we are doing right now is only creating these narrow algorithms that fit each of these little boxes. So for instance, we might create a algorithm for knee osteoarthritis. So, and then, or we might create something using for ultrasound. But what we are a long way away from is having a very generalized view of how a radiologist thinks about these things and how they have to integrate lots of different algorithms, lots of different problems, and be able to do lots of different diagnoses. If you think back to the list of FDA-approved algorithms, you'll notice that each of them fill in a very, very tiny box of this. So they're exceedingly narrow. So for instance, if you have a lung nodule algorithm, it may do a great job of finding lung nodules, but if there's anything else, like a pneumonia or pneumothorax or something else, it may completely miss that. On the other hand, a radiologist is not going to just be looking for only lung nodules or only pneumonia. They have to actually survey the entire landscape and try to find all the possible findings. So that's something we are a long way away from having, is more generalized algorithms that can consider many different problems. So again, most applications to date have been segmentation, classification, regression, so very, very fully supervised type tasks. Here's a very interesting area that is starting to that we're starting to see some work in, which is in the reconstruction of the image. So typically, what happens when you acquire the image is you acquire, especially in MR or CTs, you acquire something in a different domain than the final image. You acquire case space or sinograms, and then you reconstruct the image. And what we are starting to see is the use of these algorithms to improve the signal to noise ratio or to improve the acquisition time so that you can use deep learning for reconstruction and be able to go from here to here pretty well. I'm going to touch briefly upon COVID. Again, this is a timely topic, and there's a lot of people working in the area of COVID. So the question is, in the US and in some places, chest x-rays are typically used for assessing the severity of COVID. In some places like China and Europe, CTs are used, and CTs provide a lot more information, but there's also more radiation, and there's also concern about is it useful, you have to decontaminate the system. So there's a lot of reasons why the US American College of Radiology has advocated against using CT, but prefer the use of chest x-rays. The chest x-rays, of course, are not specific and not sensitive potentially to COVID. But the question is, can you, given a bunch of chest x-rays, can you say which of these patients is going to get better, who is getting worse? Is this patient going to decompensate? So looking at a variety of chest x-rays, can you create an algorithm to come up with a severity score? So right now, there's no severity, no single standardized way of assessing chest x-ray severity for things like COVID. So our goal was to create a standardized system that based on expert annotations of these lung x-ray severity. So the goal was, the algorithm was based on something called a MRAIL score. So it's a modification of the RAIL score for lung edema. And there, essentially, you can see going from the top here to the bottom here, more and more of the lung is affected as you go here. So the scale indicates how severe the disease is for the lungs. So what we trained is using a pre-trained algorithm and having annotations from multiple experts. We created a disease severity algorithm using a Siamese network. So the idea with the Siamese network is you have a contrasted loss function, and then you look at the Euclidean distance of the final thing. We have a MSE loss to update the weights. And so given a new image, you have a pool of normal images, and you compare this image to all of the normal images. You get a median disease severity score and use that as a proxy for the disease severity. So using that approach, we were able to create a nice score that agrees with the expert annotation of lung severity, and also use occlusion analysis to find the part of the image that might be most concerning. What we notice is that this scale allows us to potentially predict who is going to be at risk for instance, intubation or death. And if we see that if you have a score of higher than 8, you are at much, much higher odds of getting very seriously sick. So going on from that, so that is an algorithm for COVID that we're working on, and we are hoping to start to deploy it for some experimental tests in our systems shortly. As you may have all been aware of, it's really getting very easy to create algorithms today. In fact, this was a nice study where they had clinicians with no coding experience essentially just use AutoML to train an algorithm based on some annotated data. And we can see not too far away from now, if you have data and annotations and on AutoML, you can come up with an algorithm. It might actually write your paper for you, because as you saw here, this was an abstract that was written by the AI algorithm. So we're getting to the point, especially these days with a lot of the generator models, that you can get to having very, very impressive behavior. But it's really, really hard to create an algorithm that's robust, unbiased, fair, self-aware. All of these things are very challenging in imaging. So as we talked about this, we need a lot of data, and the medical imaging tends to be small. these models do not generalize well. So when people have studied how well these algorithms generalize in external validation, only 6% of the published literature has external validation. Data heterogeneity can lead to very, very poor model performance. The heterogeneity comes because you have data from different scanners, different populations, different disease prevalence, different settings, different annotators. And so this is a kind of data heterogeneity. So here you can see that the prevalence of disease is different between these two institutions. So here it's 1/9, whereas here is 2/3. You might have a lot more data from one institution compared to the other. You might have different scanners that are used. And what we see is that this is a case of mammogram data. You can see that scanners, the histogram of intensities looks very different. And an algorithm trained on scanner A does really poorly on scanner C. Similarly, the algorithm trained on scanner C does really poorly on scanner B. So these things can greatly limit the ability to use your algorithm in a setting different from where it was trained. And if there's an area that really requires a lot of people to be thinking about is how to make these algorithms much more generalizable, how to think of out of distributions, how to think about the fact that you may know ahead of time that it's going to work or not work. And so those are the kinds of questions that I think will make a huge impact as we think about deploying these algorithms in the clinical setting. Here's another example is the performance of the algorithm can vary as a function of race. It works really well for this population, but really does not work as well for the subpopulation. So thinking about how we build robustness is something that we really have to think about. So along those lines, there's a lot of effort in collaborative learning. And so we'll talk about that. So in general, again, as we said, we need lots of data from lots of different sites. And one way in which people have typically done that is a central database. So if everybody's willing to share the data, you can put it into a central database. And there's many examples of where this has been done successfully. And now you have data from different institutions, different populations, different annotations, and maybe that can be used to build more robust. But these days, and always, because of privacy issues, because of the need for de-identification, there's a lot of concern about sharing the data into a central location. There's also this sense that the data is your new oil. Hospitals and other institutions don't necessarily want to give the data outside. And moving large data sets around is cumbersome. So the question is, are there ways of collaborative learning where you can learn without essentially moving the data, but moving the model around? So a couple different things that people have studied is model ensembling, of course. So you train a model at each institution and then finally create an ensemble model. You can, federated learning is very popular these days. So essentially you have multiple institutions where the model weights are exchanged and model weights are updated based on these local training, but the data itself remains within each institutional firewall. Or you can do cyclical weight transfer, which is essentially you train here, update the weights, and keep going in a cycle. There's also split learning, where the intermediate layers of the network are on a central layer, central server, but the beginning and the end of the network is at each institution. So in model ensembling, essentially you just ensemble it. Federated learning is done either using weight averaging or gradient averaging, can be synchronous or asynchronous. There's a number of concerns that I'm not going to in here, but there are some resources here if you're interested in this topic. The training data are not IID, that they can be unbalanced. There's limited communication. So there's a couple of different ways of doing this. This is the federated averaging and SGD are the ways that we think about it. So here's an example of a study that we recently did, where we looked at the using federated averaging across federated learning across many institutions in a real life scenario. In a single weight transfer, essentially you just do this single and cyclical weight transfer. You keep updating the weights till the model performance is saturated, and we show that this can actually give performance that's very similar to a centrally hosted institution data. The other thing to think about is very often when you have very rare diseases where each institution may not have enough data to train a robust model. So for instance, here, the model performance for each institution is essentially random, but by collaborating over a large number of institutions, we start to get model performance that essentially approaches that of a centrally hosted system. Here is split learning, which is another way of doing this. So there's a number of different ways in technically that you might be able to set this up. And also but there's a lot of logistical concerns. So you need to have consortium with willing participants. Everybody needs to agree on what the clinical problem is, what the data set is, what the ML architecture is, how you're going to do the annotations, what is the infrastructure to enable secure communication, what is the IP and publication strategy. And so there's many different things to think about as we are setting this up. So there's also questions about differential privacy that's being used to address security and privacy concerns. Finally, I just want to very briefly touch upon the fact that there's a lot of concern, justifiably, that AI is not just learning our biases, but is amplifying them. And we saw that in some of our data as well, that the racial biases that are might be present in a system get encoded and amplified. So we need to think about the question of equity versus equality as we're setting thresholds, meaning do we set the same threshold for everybody? Do we set a population-specific threshold? How do we make sure we're ensuring fairness? What is fairness? Finally, just want to touch upon the resources available for medical imaging. So the MONAI is a new effort by a large number of sites across the globe to create an open source framework for domain-specific practices. So this is work with NVIDIA and King's College and a number of other places. And so here are some of the folk that are in the MONAI group. But the idea with this is that we will have a unified framework that can be used for medical imaging tasks. So if for those of you who are interested in medical imaging and are interested in being part of this community, I highly encourage you to look at this framework, be part of the communities, look at the existing code and examples, feel free to make contributions. It's a very open community. There's a lot of work happening, for instance, at MICAI. There's other hackathons and other things happening with using MONAI. So please do look at that. So the goals are to have a variety of pre-populated and easy to use notebooks. So there's segmentation classification tasks. There's a variety of work in federated learning. There's I/O, how to deal with imaging data, how to deal with 2D, 3D, and so on. So there's a lot of interesting features that will be coming shortly. The version 2 was just recently released. There's another version coming shortly. So please stay tuned there. So I just would like to summarize by saying that there's a lot of great potential in healthcare and medical imaging, but lots of challenges remain. Validation is very important, and we really are yet to see prospective validation on external data sets. So thinking about building robustness as you're training the model, thinking about generalizability, thinking about evaluation, bias, all of these things I think would be great for those of you interested in this field. So I think with that, thank you.
Thank you so much for the talk. I think we have a few more questions. I'll start with, is there a use of semi-supervised learning in medical imaging?
Yeah.
Even we have a less amount of annotated data, and I think what would be good pretext tasks for it?
So yes, there is, to date, most of the published algorithms as well as the approved algorithms are all almost entirely fully supervised. But of late, there's been a lot of interest in semi-supervised methods. It's a really good point, but there's a lot of challenges. So a concern is if the performance gap between the semi-supervised and the fully supervised is not closed, people are still not going to use it because you really want the best, because it's a healthcare problem, you want the best possible algorithm out there. And if the best algorithm out there requires a lot of annotations, it's still potentially worth that because it's, again, a healthcare application. However, if you can start to narrow the gap between semi-supervised and fully supervised, and also if you can use the large amount of weakly supervised data that you have out there, for instance, so if you have annotations on many thousands of people or millions of people in your hospital that are not annotated the same level. So how to combine semi-supervised methods to narrow the gap is an area of research.
Right. So there's another question. Are there any pre-trained models for 3D images of various modalities like MRI and CT scan?
Unfortunately, not yet. They're starting to see a few. There's a large effort that will be coming up soon to create a medical image net with the idea of exactly that. So to create essentially take all of the lung CTs or the brain MRIs and pre-train a model and make that available. So there's some efforts, but it's nothing like ImageNet yet. But there is great interest in making that happen.
Right. So another question is, how can we integrate medical priors with traditional DL pipelines? Recently, there was this work which takes in multiple viewpoints and also takes multiple normalization window scales and lengths, because that is how radiologists check when they are confused about the presence of a particular lesion or anything. And it achieved very good results. So what are your views on this?
I think that is a good point. So we very often, if you're talking about, say, there's an example from the intracranial hemorrhage, where what they showed is that by actually looking at, instead of having 3 channels, if you have 3 channels that are 3 different window level settings, so it's like bone window and this window and that window, you actually get pretty good performance. So really understanding how the radiologists look at things is a good thing. But I 100% agree that the multiple normalization and window scales can be quite useful. And definitely something to consider is how many different channels and what the optimal settings is. The other thing to think about is very often, and here's a question that we continue to have, is the best Windows level setting for a radiologist the same as for an algorithm, right? In a sense, we actually have all of the information. We have 12-bit data, 12 or 16-bit data that we acquire it at, but we very often convert it to 8-bit. So we're actually throwing out a lot of information. Is there a way that we can continue to keep the rawest information, so whether it's cyanogram data or case-based data or even just 16-bit data, in such a way that we're not losing information, so that we don't necessarily have to do exactly what the radiologist is doing, but find the best window level settings for the algorithm. Again, an area of research, but for now, I think it's definitely worth at least trying the 3 window level settings that the radiologist might use.
Right. Another question is, can you tell us a bit more about class imbalance problem in medical imaging and how to deal with this?
That is an amazingly difficult problem. So very often we have class imbalance in multiple ways, right? So we have very often the disease patients are very small. So maybe 3% of the population has got the disease. Or even within the image, maybe 1% of the image has the finding. And how to think about that is something that needs a lot of thought. So one way people do it is obviously equal sampling during training. So try to oversample the minority classes. You can do weighted cross entropy. So there's ways to handle the class imbalance, but it's very much of an issue because both on a patient level and on the part of the image that's of concern, there is a class imbalance. What we have seen is depending on how you do the weighting during training, so equal sampling versus random sampling, you might end up with very different proportions of the different classes. So it's important to make sure that eventually you're representing the true finding, the prevalence of the disease, especially for something, if it's not just binary, but on a scale. So if you have 1, 2, 3, 4 level, you need to make sure that at the end of that, you have the same relative proportions of all the classes as you expect to have in your population.
The next question is, you had mentioned that the model might miss out on one disease while detecting another. So are there multi-label classification methods to deal with this?
Yes, also a very good question. So the way people have typically done it, so there's 3 ways to think about it. So you can have an algorithm that is, does this chest X-ray have pneumonia or not? Does this have pneumothorax or not? Does it have this or not? So you can have one versus this. for each disease, you can have an algorithm that does that. And then you finally take the output of all of those algorithms and say what all might be there. You might have a multi-class problem where it's mutually exclusive, though that's not typically the case, because you can actually have patients with multiple comorbidities, meaning a patient can have multiple diseases at the same time. So it's important to make sure that you're not setting it up as a one versus all. You can have multiple possible positive outputs. The other thing is that another way people are thinking about this is this normal versus not. So is this essentially putting together all of the abnormals together versus just normal? Can you look at this chest x-ray and say there's nothing wrong with this patient and they can be cleared, and then think about how to classify them? So different ways in which people are setting up that problem.
Okay, another question is that can you discuss a few ways on how to improve contextual modeling?
That is a good question. I don't know if there's, again, a perfect answer right now. So there's ways to think about anatomy. So bringing knowledge from that. So for instance, you have, you typically know what the anatomical structure of the human is supposed to look like. So there's a way to build that in. Certain diseases have certain patterns, certain findings, certain spatial locations. So good area of research, very little practical work has been done yet. But building in knowledge in the form of, or context in the form of anatomy is one way to think about it. In the way of disease progression is another way. But I don't feel like we have a perfect answer yet.
Also regarding the high computational cost that 3D models require, and also that they are prone to overfitting, considering the limited amount of medical data that we have. So what are your views on this?
It is a challenge. They are definitely prone to overfitting because of exactly that, because we have very small amount of data relative. I mean, if you take each pixel separately, you have a lot of data. If you go to the slice, it's still less data. But if you look at a study, now you're only talking about hundreds of cases. So it's very much prone to overfitting. Ways in which people have thought about that is looking at 3D patches, for instance. So looking at sliding windows and patches. But there's very much a risk of overfitting. So sometimes people do continue, even though we do have 3D, people tend to take a 2D ImageNet pre-trained model and do it on a slice-by-slice basis, and then maybe do some sequence modeling to then go from a slice level to a 3D level.
Right. A follow-up question regarding the rare cases in medicine, such as diagnosed diseases. With my limited understanding, researchers are proposing methods to generate the synthetic data of these rare cases. Could you please share your opinions about the limitations of those methods? What should we do to improve it?
That's a good question. It's a really good question. And there's a lot of work in using GANs and other things to try to synthesize, put in and take out lesions, to essentially to get a lot more data by being able to, if you understand if you can model it in a way that you can put in nodules of certain characteristics in certain locations, you can synthesize in essentially infinite amount of data that can be then used for training your algorithms for other things. The concerns include, do you have a good enough model to truly represent all of the diversity of the disease presentations? Because especially for the rare diseases, you may not. How do you train a good way of synthesizing the data? So there are a number of people working in this area on synthesizing images with the ability to say, okay, put a tumor here, make it bigger, make it of this type, make it more speculated, make it more smooth. And it seems like a pretty interesting area to pursue.
Another question is it possible to predict biophysical features of brain tumor using TL on 3D MRI modalities, and some ways you can suggest?
Good question as well. So the people are looking at things like, so if you have a tumor, what it does is, for instance, when it you have something called a mass effect, which is meaning that the tumor is pushing out normal structures. So if you look at a deformation field as a tumor is growing and look at what the effect of that is, you can look at the strain. And these properties of the, looking at the DL models, you can actually get a pretty good local estimation of the effect of things like mass effect, which are can be used to build more biophysical models. We've looked at this in terms of drug delivery, for instance, as well. So as you understand the local microenvironment of the tumor, you can tell if the drug, what is the way in which the drug can diffuse into the tumor, into the normal brain, how does that affect response? But a good area of research, again, not a whole lot of work that's done yet, but trying to understand the local strain characteristics as well as mass effects is one way in which people are looking at the biophysics of the tumor.
Okay, I think just the final couple of questions. A question is, how are there any other approaches other than class activation mapping or such approaches to check what area or what exactly your model is looking at while predicting, so that it can help with more robust or explainable predictions?
It's one of my favorite topics. We are looking a lot about the different saliency maps approaches. If you actually look at the saliency map approaches, whether it's GradCam or XRAI, or many different approaches have been proposed in the literature. Unfortunately, if you actually do a fully quantitative study of that in a case where you actually know where the finding is, you find a lot of suboptimal performance. So our personal view is that if you really want explainable AI, think of a model that's more explainable. So build that into the architecture. If you want localization, build a RetinaNet or build something that has detection. If you want or use segmentation, but combine something that has at least some level of localization inherently versus a post hoc type method.
Great. Thank you for sharing your insights regarding generating synthetic data. I'm also interested in processing ICU instrument data. What's the challenge in this area? What should we pay attention to while processing it?
The ICU instrument data it's temporal data. Has a lot of missingness, meaning that not all it's hard to model because it's not as regular. Some streams will come and go. You have to deal with various amounts of missingness in the data. The time frames can be quite different. So some signals are very short term, some are much longer term. It's a challenging topic.
Right. I think that should be it. Thank you so much for answering so many questions. And thank you so much for this wonderful talk. It was really informative.
Thank you for having me.
I think that's it then. If there are no more questions, we'll switch to the next session. Thank you so much again.
Bye.